Good evening, everyone. Thank you for being here tonight, resuming our lecture series in SAMS. It is my pleasure to introduce to you today Dr. Yasmine Chebbi, who graduated from Harvard School of Dental Medicine in Boston. She grew up in Miami, Florida, graduated from Florida International University. Just quick notes about Dr. Chebbi. She speaks 4 languages, English, Spanish, French, and Arabic. She's a member of the Massachusetts of Dental Society and American Dental Association. And also, she is the holder of Academy General Dentistry Board, and she is a diplomat of the American Board of Dental Sleep Medicine, which this is the first time I hear about it. It's really very interesting, specialty, and it's the leading national testing organization for dentists who treat snoring and obstructive sleep apnea with oral appliance therapy. We thought the subject is very interesting, and it will appeal to a lot of our members. So for that, we had the pleasure of inviting her to have a talk in titled on Multidisciplinary Approach for Pediatric Sleep Disordered Breathing. Without further ado, it is my pleasure to have Dr. Chebbi here on board to give you a very interesting lecture. And I'd like to just ask if you have any questions, please. We're going to have probably 5 or 10 minutes at the end to answer these questions. So thank you very much. Dr. Chebbi, it's all yours.
Good evening. Thanks for having me. I hope this is interesting to you all. So we'll dive in. Today I'm going to be speaking a bit about the dentist's role in pediatric sleep disordered breathing. Great. So what I'm hoping you will take away from our talk today is learning about the epidemiological factors that are increasing sleep disordered breathing in children. To learn that helping children requires a multidisciplinary team. I hope you'll also learn some common misdiagnosis and the delaying treatment could affect the future financial, professional, and health success of the child, and how a dentist can be part of that multidisciplinary team. Great. So as Dr. Warif mentioned, I currently practice in Boston. My disclosures, I'm an author of the book Eat, Sleep, Breathe, Oral Health, Why Your Mouth Matters, and I consult for some sleep apnea related companies. All right, let's dive in. So why is sleep disordered breathing increasing? So in order to learn about why it's increasing, let's just do a quick recap about what causes sleep apnea. So usually when we are breathing, so sleep apnea is caused by an obstructed airway. So usually, if you can see the diagram on the top, when we're breathing at night, air is coming in through our nose, maybe through our mouth, and is going back to the throat and down into the lungs. During obstructive sleep apnea, that channel is closed and it doesn't allow a person to sleep well. So what is causing an obstructed airway? Well, it could either be from inflamed or enlarged tonsils and adenoids, so that increased tissue kind of blocks the airflow from the nose and the mouth down into the lungs. It could also be that the tongue is pushed down and back into the throat, also causing that closure of the throat. And that tongue can be pushed down and back either from a tongue tie, which doesn't allow for more mobility of the tongue, or what we could also consider is the tongue doesn't have space in the mouth or in the roof of the mouth. So it is being pushed down and back, which is causing an obstructive airway. Okay, so just as a quick recap, I just wanted to show you these different areas of an obstructed airway. Could be coming from enlarged tonsils and adenoids, so inflamed tissue causing the airway to be blocked. It could also be caused from a tongue being pushed down and back to the throat, which could either be from a tongue tie or having a small mouth or having mouth breathing. Basically, when the tongue is pushed down and back, that's when we can get some closures. So, okay, so great. So we're gonna go back to reading this quote together. So this is from, an explorer anthropologist, George Catlin, in the U.S. in 1870. And so he would travel around and look at different Native American tribes, and he was making some associations. Now, so we'll read this together. So he found that breath inhaled through the mouth sapped the body of strength, deformed the face, and caused stress and disease. On the other hand, breath inhaled through the nose kept the body strong, made the face beautiful, and prevented disease. He went on to say that mothers carefully closed their babies' lips with their fingers after each feeding, and at night they'd stand over sleeping infants and gently pinch their mouths shut if they opened. So you can see that even in the 1870s, the wisdom of other populations, of Native American population, they knew the importance of being able to breathe properly through the nose, and they understood that mouth breathing could be very detrimental, not only for energy and growth, but even for changing the face. So this is not a new concept. This has been around, as old as time. So we'll play a bit of a game here. These are some popular actresses, American actresses from different times in history. And just, think to yourself from these, which are the ones that are current day actresses? If you guessed the two on the bottom, you would be correct. And what's interesting is that you can see that our faces over time are changing. Our faces are becoming flatter, our chins are getting pushed back more, our jaws are becoming smaller. You can see the top row of actresses from the early 20th century, and now we have our current day actresses, and you can see how quickly our faces are changing, and how having a smaller face or a more pushed back face can also affect how much space we have in the back of the throat for proper breathing. So that comes to our next point, is to why is sleep apnea increasing? Great. So for one thing, our mouths in general are getting smaller. Some studies show that up to 90% of children have malocclusion. These days, it's almost a rite of passage or a given that children are going to need braces, right? But that was not always the case. We actually even have pictures of older skulls from other times where the teeth were very straight and the arch were wide and well placed, and these ancient populations didn't need braces. Malocclusion is a pretty new concept from the industrial age. Why else could sleep apnea be increasing? Well, in general, I think it's getting harder to breathe for different reasons. If there's an increase in obesity, then having that extra soft tissue could make it a reason why sleep apnea is increasing in adults. We also have an increase in allergens and just day-to-day pollutions, whether it's inside the house or in the outside, and that could cause some stuffiness, which could lead to mouth breathing and a risk for sleep apnea. Our faces are also changing. So not only, our environmental exposures, but some studies show that bottle feeding and using pacifiers and an increased use of soft baby food does not allow a baby to use their jaw muscles as much for oral development and for developing of the jaw forward. When a baby drinks or nurses from their mother, that strong pressure causes the jaw to kind of develop. It trains the muscles and can provide studies might suggest that it could provide a more favorable face structure for proper breathing. So now that we understand a little bit about why sleep disordered breathing is increasing, let's take a look at some signs of sleep disordered breathing in the pediatric population. So this is a classic face of a child that might be suffering from sleep disordered breathing. And I'm showing this one to you today because this could be a child that comes to see you in your practices with undiagnosed sleep disordered breathing. And it'd be good to start understanding what are some signs that we can look at so that we can help these children. One classic example is called this long face. So when a child is not able to breathe through their nose and they breathe through their mouth, that slacking of the mouth and not having the mouth closed and the tongue up to the roof of the mouth starts creating a long face. There's some venous pooling under the eyes. So these shiners under the eyes can also be indicative of chronic nasal congestion and mouth breathing. Open mouth and lip strain, a narrow nose as well. So if they're not using their nose as much, you might find that they start growing a more narrow nose. Concave profile, retrognathic chin. For us in dentistry, that basically means that normally we want our chin to sit pretty much in line with our lower nose there, with our upper lip. So if it's more pushed back, we're thinking that the jaw is underdeveloped. And you can imagine if the jaw is more pushed back, we don't have enough space in the back of the throat for breathing. A gummy smile, so when a patient smiles and you see a lot of gum tissue in the top, that's also indicative of having a long face and improper growth. And concurrent with that, having open mouth or lip strain, not being able to close the mouth well, again, another sign of having a long face, maybe some enlarged tonsils and adenoids, but indicative of breathing through the mouth and not being able to breathe through the nose. And another thing that these children might have is poor posture. So posturing their head forward in order to get a better breath. You might notice that as well in those patients. And these changes can happen quickly. Here is a case study of a boy at the age of 14, I believe, who was given a cat in the house as a pet. But it turned out that he was allergic to the cat, so he was chronically congested. And in just a few short years of not being able to breathe through his nose during important growth times and growth spurts, you can see the quick change in his mouth and in his face by not being able to breathe properly and form his face properly. So now here's just a couple of other examples there to kind of drive the point home of the kind of faces that we're looking for in these patients that might have a higher risk of sleep disordered breathing. We have the venous pooling under the eyes, not being able to close the mouth properly, having, again, the open mouth posture, crowded teeth, narrow nose, long face. So I've talked a bit about what we shouldn't have, but from a dentist perspective, what should a healthy mouth look like? So in a healthy baby mouth, we want to see a lot of space. Baby teeth are meant to hold the spaces for the adult teeth to come in. For the most part, adult teeth are larger than baby teeth. So having a lot of space is important when we have baby teeth. If baby teeth are crowded, then we can almost assume that the adult teeth are not going to have enough space. And crowded teeth might also mean that it's a small jaw, that there's not enough room for all of the teeth to come in the future. We also want to make sure that the patient doesn't have a tongue tie, which basically means that the tongue can move around, it can sit up at the roof of the mouth and provide the proper support. And we don't want to see any grinding of teeth. Sometimes grinding of teeth in kids could be a sign of having a stressor, and that stressor could be not being able to breathe well at night. And here's just a little bit of an example of what a tongue tie can look like in an infant who may not be able to bring the tongue up for breastfeeding and proper function. And then after they do what is called a tongue tie release, there's more freedom of movement for that tongue to properly function. And I think another very important point that I would like to drive home this evening is that children are very good at compensating. So when a child undergoes a sleep study, for example, they only need to have what we call one episode of an AHI. So they need to only have one apneic episode to be considered having sleep apnea. Whereas with adults, having apneas of 1 to 5 is considered not having sleep apnea, and 5 and above starts in the mild, then the moderate and severe categories. But children are very good at compensating. So we want to make sure we're looking for those compensations when they're sleeping, because it is, just a survival technique for these kids. So we might see them with their mouth, a little bit more postured forward, some more efforts during breathing. So it's just important to know that even if a sleep study comes back negative with no apneas, it doesn't mean that the child isn't putting forth effort to try to breathe at night. So it's important to take a look at the whole picture. Great. So now let's take a look at some common conditions associated with sleep disordered breathing. Perhaps some patients that may come to you for your expertise in different specialties, and try to learn a little bit if sleep disordered breathing could be a part of that puzzle. So sleep apnea could be associated with ear infections. Sometimes if there's an increase inflamed tissues of tonsils and adenoids, it may not allow for proper clearage or drainage of the eustachian tubes, which can also lead to ear infections. Chronic nasal congestion, again, if a patient isn't able to breathe well through their nose and they're compensating with mouth breathing, that could be associated with chronic nasal congestion. ADHD is a big one. About 25% of patients with sleep disordered breathing also have a concomitant diagnosis of ADHD. Often we want to make sure that we are decoupling a sleepy child from a child who has ADHD. So always important to add that into our workup. Another thing is acid reflux. So the negative pressures of trying to breathe at night and not being able to take a proper breath could cause acid reflux. So another important thing to think about if a child presents with acid reflux, to be taking a look to make sure that the sleep is okay. Picky eating is another one. Picky eaters usually have a very sensitive gag reflex, or they're very protective of their airway. And so if a child doesn't like eating hard to chew foods or dry foods, it could be kind of a survival or compensation because their airway is a little bit more compromised. Oral habits is another one that we might even see in the dental office. If a patient is thumb sucking or really relies on their pacifier into late childhood, it could be they're trying to move their jaw more forward in order to get a good breath at night. So we want to be taking a look at those things as well. And a big one in our field is cavities. So if a patient is breathing through their mouth mostly, then their nose, that dry mouth can be a really big cause of cavities. So it may not be that they're just not brushing and flossing enough. There could be something else going on underneath the surface. So another point that I want to make today is that it does take a multidisciplinary team to help our future generation. First, it starts with public health awareness, teaching parents that snoring is not, it's not cute. It could be a sign of something else going on. Painful nursing, painful breastfeeding could be a sign of the tongue not being put in the proper position. So public health awareness is our first step. Then we want to engage our pediatricians and our general dentists as the first screeners of these patients. These are usually the first people, the first providers that these babies see, and being able to look for these signs and have conversations to parents about who to refer to would be important. Of course, we need a sleep doctor, pulmonologist, neurologist for diagnosis and immediate therapy when indicated. We also need the help of an allergist to help with nasal congestion and allergies that can lead to chronic mouth breathing. Of course, our ENTs are very important to take a look at deviated septums, to take a look at enlarged tonsils and adenoids that might be indicated for removal. A psychologist is very important to have on the team to manage the behavior of these children, and to be able to look at ADHD with more of a nuanced perspective. And then the dentist is also important for structural changes of the mouth and oral complex to make more room for the tongue and the teeth when indicated to help with breathing. So I think it's just important for all of us to know what the others can provide in order that we can make proper referrals for our pediatric patients. Next, I'd like to explain a little bit about how a dentist can be a part of the team for pediatric sleep disordered breathing. So if you remember our slide from the beginning of the presentation, we talked about the different reasons for sleep apnea. And in the end here, I mentioned that it could be an issue with the tongue, either when the tongue is pushed down and to the back of the throat. It could be because of a tongue tie, so the tongue does not have the mobility to move up and out. It could also be if the roof of the mouth is small and the palate is small, then the tongue is not able to sit up to the roof of the mouth where it belongs. We want the tongue to be up next to the back of the front teeth. We don't want it to be sitting low. That's the best place for the tongue to get it out of the way of the airway. So this slide just kind of shows you a little bit about why dentists care so much about the tongue. I like to explain that tongue is sort of nature's orthodontics. So if you can see in this large picture here, we like the tongue to fill up the whole roof of the mouth. That allows the pressures to be pushed onto the roof of the mouth and create the proper space for these for the teeth and for the maxilla. When we have low tongue posture, as you can see on the images to the right, then the cheeks are kind of pushing the teeth in, the pressure, the muscles of the cheeks, but you don't get that that concomitant pressure of the tongue pushing the teeth on the roof of the mouth out. So because of that, we don't get proper expansion of the roof of the mouth or of the maxilla, and we get more of a narrow, or what we call high vaulted palate, because the tongue is sitting down lower and not pushing up to do that expansion. Here's just a little bit of an example here. Perhaps the ENTs on the call would know this pretty well. This is just an example of the different variations of a tongue tie, grade 1 being very functioning, grade 4 being a severe tongue tie, and everything in between. So you can see that when we have a tongue tie, we are not able to move to the roof of the mouth to cause that, that proper expansion. And so just to clarify, perhaps I keep speaking about the roof of the mouth and how it can pertain to sleep and breathing. So just to clarify, the roof of the mouth is the floor of the nose. So if you look at this anatomy here, they share the same structure. So by increasing the space of the roof of the mouth, we are essentially also increasing the floor of the nose. And studies show that a 1 millimeter increase of expansion of the maxilla can lead to a 2.5% increase in the nasal volume cavity. So increasing the roof of the floor of the nose or the roof of the mouth can help with breathing as well. So these are just a couple more examples to drive the point home of what a narrow palate might look like and what an expanded palate might look like. And you can see how that might relate to the space provided not only in the floor of the nose, but as well as creating more space for that roof of the mouth. And you can see how that kind of expansion and more room can also, change the face shape. And this is just a diagram here so you can see when the tongue is pushed up where it's supposed to be, up to the back of the top teeth, we get proper facial growth, outward growth. Whereas if the tongue is sitting down and low, we get that long face, low growth that you can see on this photo here. So here's a case of one of my adult patients. So this is a sleep apnea patient of mine. And now from everything that you have learned, you can understand a bit about this patient's risk factors, right? So firstly, you can see here with the tongue, he has a bit of a tongue tie. So it tells me perhaps when he was younger, we didn't get that that push from the tongue to expand the roof of the mouth. You can see that the tongue is kind of overflowing or splaining over the teeth there. So the house that the tongue is in, you can see is quite small. It doesn't have any room here. In this second photo, you can see how this patient might be at a risk for sleep apnea because you can barely see down their throat. They have a Mallampati score of about 3, approaching 4. There's not really a lot of room there for breathing. This circle here where I highlighted the teeth, this patient is missing premolars and wisdom teeth. So this patient had teeth removed when he was younger because there wasn't enough room in the mouth for those teeth. So instead of making the teeth, the mouth bigger, making the spaces bigger, teeth were removed to fit into a smaller space. And this last photo here with these sides is just to show you how much room, what could have been possible for more expansion. You can see it's a small arch or small set of teeth where we could have had a little bit more room. So, kind of my last thoughts here is that in general, when we have a patient with sleep disordered breathing, working with an airway-minded dentist could be helpful because it focuses on the child's symptoms. It also works on early intervention that works with the child's growth. So working with the child's growth spurt and facilitating that kind of growth and movement, it makes it a lot easier when the child is younger than trying to make things fit into a skeleton that's kind of already formed after the growth spurt. Airway-minded orthodontics is a little bit more expansion-focused as well. And because it's focusing a little bit more on the root cause of what caused the crowding and the issues like that, there's less chance of relapse because the body doesn't fight it as much. Here is a patient of mine. She is 4 years old, and you can see that she has some venous pooling under her eyes. She has a little bit of a longer face. Her chin is recessed. When we take a look at her teeth here, we can see that she has some crowding in the lower teeth. We have a little bit more of a narrow arch and what we call a deep bite. Things are a little bit more pushed in. Our plan for her early orthodontic stage is to create more room. So you can see the black arrow versus the yellow arrow, making more room for these baby teeth because then the adult teeth will follow in that place. And the idea being here, if we can make more room when the child is younger, more malleable, it might reduce the chance of more intervention when they're older with traditional orthodontics. So my take-home message for tonight is to be able to understand a little bit more about sleep disordered breathing in kids and starting to understand a bit about how we can screen them and how we can work as a team to help them. And it's important to help them now. Children with poor breathing and poor sleep at night could produce less growth hormone. So they might have a failure to thrive because sleep is very important for growth hormone. They may not be able to concentrate in school, and they may not have good academic performance because they're sleepy. They might also be punished for behavioral problems, again, because children tend to not behave as well when they're feeling tired and they don't feel well. It's important to remember that children who snore at age 3 are 3 times more likely to have lower school performance at age 13. So these changes couldn't have effects into later on in childhood. And as you probably remember from development, 90% of the brain grows by age 5. So this is a critical time to be looking out for these issues with children. And these things, of course, there are ramifications in childhood, but as an adult, we want to consider just not concentrating at school and having behavioral problems. Will this affect their education and job opportunities because of their academics? Patients with sleep apnea have a higher chance of weight gain, of medication-resistant hypertension. They're more at risk for anxiety, depression. They might have poor posture, jaw pain, and hearing loss. So these are all things to consider when we are evaluating our patients. And great, that is my talk for today. I hope you all learned something, and thank you very much.
Thank you very much. So I'd like to open the forum now for questions, and I bet there's a lot. So yeah, please just raise hands for the next question. I have Dr. Ihab. Please go ahead.
Okay, thank you so much for the presentation. I really learned a lot. I actually take care of adults, so this is kind of new to me. But I'll tell you, for adults, I have been ordering so many sleep studies, way more than I did when I was a resident and training. And I'm just wondering, for children, what are the implications for sleep testing? Do we order them liberally as we do with adults? Do we order, is the shiners under the eyes, is that sufficient to order a sleep study, or are there specific indications to narrow the number of sleep tests in children? That's one question.
Yeah, wonderful question, and very important to make sure we're not over prescribing. There are some different questionnaires available online that could be helpful. In general, there is a CGASP form. So just like there's a GASP form for adults, there's one for children as well. Some things to keep in mind for children, like I said, restless sleep, any snoring, having a conversation with parents, being restless during the day, not waking up, not feeling refreshed, having delayed bedwetting, so a child who is wetting the bed a little bit later than developmentally expected is important as well. Having nasal congestion, crowding of teeth, like I mentioned, yes, shiners under the eyes, sleeping with their bottom in the air, right? So sleeping with their face down, cranked up, having bottom in the air. There's quite a few questionnaires that parents can fill out as well that could be helpful. Of course, not all of them, exactly like you said, are indicative of having apnea, but kind of put together with clinical signs and symptoms might lead to one suggesting that the patient have a sleep study. Having trouble breastfeeding when they were younger is also one as well. Thank you.
One more question, if you don't mind.
Sure.
Should we also encourage children to sleep on their side as we do with adults, or is that just for adults and there's a different recommendation for children?
Oh, yeah. Great question. So I think one thing to consider for children is, of course, in adulthood, sleeping on your side is just healthier. I think, we could recommend that for children, but another thing to think about for children is when it comes to sleep apnea, we really try to not only manage it, like positional therapy, we really want to focus more on curing it, right? So I think it's a good short-term solution, but kids are very restless. They move around a lot. I think more importantly would be getting to the bottom of it and seeing if we can help them so that they can sleep in whatever position is comfortable. good question.
Thank you so much.
Anybody? I don't see other hands. I have a question to.
Oh yes, there's a question in the chat.
Oh yeah, I'm sorry. Yeah, Dr. Amjad, you have a question. Go ahead.
Yes. Thank you, Dr. Yasmine, for a great lecture. You touched on retrognathia and micrognathia in children. Is there any role of using mandibular expanders to deal with the dental issue and also the obstructive sleep apnea in some of those patients?
Yeah, great question. So in general, I think this is a pretty new field in terms of early orthodontics for sleep disordered breathing. So we're still trying to gather some research on the success rate. I think in general, what we do as dentists when we're focusing on expansion is that we are treating the dental issue, which we then hope will help with the sleep issue. So what I mean by that is that if a child doesn't seem to have an expansion problem, if they seem to have a wide palate, but they're still having snoring or sleep breathing issues, then they're probably not a candidate for orthodontic intervention, right? Not everyone that has sleep issues is always going to need an expander. So that being said, we, on an orthodontic perspective, if somebody needs an expander, we'll go ahead and do that. But we don't have the research yet to pair the OSA in children with the expanders right now. But I think in general, the research is trending that yes, having mandibular expansion and maxillary expansion helps to create more room of the oral structures in order to then relieve the obstructive sleep apnea if the narrow arch is the issue, right? If tonsils and adenoids are the issue, then that's, for the ENT. I hope that answers the question.
Yes, it did actually. One more question. And some of those facial malformation like we see in Down syndrome patient.
Yes.
Do you usually send those patients with severe cases of apnea to surgery like mandibular advancement and those related big surgeries?
Yes, yes. So children with Down syndrome sometimes have a higher risk of having sleep disordered breathing. Many of them, because of the severity of it, are placed on CPAP immediately. If they can tolerate orthodontics and expansion with orthodontics, we would do that, moving the whole complex forward. But sometimes, yes, surgery is indicated to just move all of the structures forward immediately. Absolutely, good question.
Thank you.
Anybody else have a question? So if not, I think we can conclude. Thank you very much, Dr. Chebbi. It is really, great to have you here and this tonight for a very interesting subject. And we hope to have you in future lectures in our lecture series, and also hopefully be part of our missions as well, if that's possible.
Would be great.
Thank you again. Thank you very much, and have a great night.